You're here because you want to get straight to the point, right? Understand what's important without wading through jargon.
Exactly. Just the key info.
So today we're doing a deep dive into gestational diabetes mellitus. GDM, you've probably heard of it.
It comes up quite a bit in pregnancy discussions.
We want to unpack what it is, why it happens, and really why it matters.
And our aim is simple, really. Give you a clear picture of GDM, the essentials, without making it overly complicated.
Okay, let's start there then. What is GDM, fundamentally?
Simply put, it's diabetes that starts during pregnancy.
So you didn't have diabetes before getting pregnant?
Correct. It typically shows up later in the pregnancy, maybe the second or third trimester, often picked up by a routine test.
Okay, develops during pregnancy. Got it. But why? What's actually going on in the body to cause this?
Well, it's fascinating, actually. It comes down to the normal changes, the hormonal shifts that happen during any pregnancy.
Normal changes, but they lead to diabetes.
Sometimes, yes. These hormones, while essential for the baby, can also make the mother's body less responsive to insulin.
Insulin, that's the hormone that controls blood sugar, right?
Exactly. It helps sugar get from your blood into your cells for energy. Think of it like a key.
Okay.
During pregnancy, some placental hormones can make the locks on the cells a bit, let's say, sticky. So you need more insulin keys.
So the body needs to produce more insulin to keep up.
Precisely. And if the pancreas can't quite meet that annual demand, blood sugar levels start to rise.
So the very hormone supporting the pregnancy can kind of inadvertently cause this issue. Interesting.
It is, yeah. A complex interplay.
Now, what does this mean for the pregnant person? If they develop GDM, what are the potential, effects on their health?
Right. Looking at the mother, GDM can bring a few challenges. One is having too much amniotic fluid. That's called polyhydramnios.
Too much fluid. Why does that happen?
It can be linked to the baby producing more urine because of higher glucose levels passing through the placenta.
Okay. What else?
There's also an increased risk of developing high blood pressure. The changes can affect blood vessels. And in rarer cases, a serious condition called ketoacidosis might occur.
And I heard it can affect labor.
Yes, that's another point. Because babies tend to be larger with GDM, there's a higher chance of difficult labor. Dystocia is the medical term.
Makes sense.
Oh, and one more thing, a greater susceptibility to yeast infections. Urinary tract, genital tract.
Wow. Okay, so quite a few potential issues for the mother. What about the baby? What are the risks there?
And this is really critical, the impact on the baby. Sadly, GDM does increase the risk of stillbirth.
Oh, wow.
And for the newborn, there's a higher chance of things like respiratory distress syndrome, breathing difficulties.
Okay.
Also, low blood sugar right after birth. That's hypoglycemia.
Why low blood sugar? Wouldn't it be high?
The baby's pancreas has been working overtime, producing insulin to cope with the mother's higher sugar levels. After birth, that high insulin level can cause their own sugar to drop quickly.
Okay, that makes sense. Any other risks for the newborn?
Yes, high bilirubin levels, hyperbilirubinemia, which causes jaundice, and sometimes low blood calcium, hypocalcemia.
And you mentioned bigger babies.
Exactly.
Yeah.
Macrosomia, a large birth weight, which ties back to the difficult labor risk, and in some cases, a slightly increased risk of certain congenital malformations.
Hearing all that really drives home why catching it early is so important.
Absolutely crucial.
So thinking about who gets it, is it random? Or are some people more likely to develop GDM?
There are definitely factors that increase the risk. Things like having a history of impaired glucose tolerance even before pregnancy.
Okay.
Maternal age is another one, typically being older, say over 35.
Right.
Obesity is a significant factor, a BMI of 25 or more. Smoking also increases risk.
What about other conditions?
Yes, having polycystic ovary syndrome, PCOS, is linked. And family history plays a role if your parents, grandparents, or siblings have diabetes.
So genetics is in there too?
It seems to be, yes. Also, finding glucose in your urine during a routine prenatal checkup can be a flag.
Okay.
And finally, a history of a previous unexplained stillbirth or having previously delivered a large baby, usually defined as over 4,000 grams, about 8 pounds, 13 ounces.
That's a pretty comprehensive list of risk factors. So if someone has some of these or just as routine screening, how do doctors actually check for GDM?
The standard approach is an oral glucose tolerance test, the OGTT, usually using a 75-gram glucose load.
Right, the sugary drink test. When does that usually happen?
Typically between 24 and 28 weeks of pregnancy. And it's important you fast beforehand, usually for at least 8 hours. No food or drink except water.
Okay, fast, then drink the glucose solution. What happens next?
So first, they draw blood to get your fasting glucose level.
Before the drink.
Yes. Then you drink the 75G glucose solution, usually quite quickly, within about 10 minutes.
Okay.
Then they draw blood again 1 hour after you finish the drink. In a final blood draw, 2 hours after you finished it.
3 blood draws in total. Fasting 1 hour, 2 hours.
That's the standard 75G OGTT protocol, yes. And you can't eat anything else until all the blood draws are done.
Right. That would mess up the result.
Exactly. That lets us see how your body handles that glucose challenge over time.
So what numbers are they looking for in those blood tests? What actually means a GDM diagnosis?
The diagnosis is usually made if any one of those results meets or goes over the threshold.
Just one. Okay. What are the thresholds?
For the fasting sample, it's 92 milligrams per deciliter or higher.
92 fasting. Okay.
For the 1 hour sample, it's 180 milligrams per deciliter or higher.
180 at 1 hour.
And for the 2 hour sample, it's 153 milligrams per deciliter or higher.
153 at 2 hours, so meet or beat any one of those, and it's GDM.
Generally, yes, that's the diagnostic criteria most commonly used.
Okay, so let's say someone gets diagnosed. Keeping blood sugar stable must become the main focus, right? How do they manage that?
Absolutely. Self-monitoring of blood glucose becomes really, really important, checking your levels at home. Initially, it often involves checking before each main meal, breakfast, lunch, dinner, and also before bedtime, so 4 times a day typically.
Okay.
Some protocols use paired testing too, checking before a meal, and then again 1 or maybe 2 hours after eating.
Why so often? What does it tell you?
It shows how different foods, different activities, and just time of day affect your blood sugar. That information is vital for making adjustments.
Adjustments to what? Diet? Exercise?
Exactly. Diet and exercise are the first lines of management. The monitoring helps tailor those recommendations. And if those aren't enough, it guides decisions about medication like insulin.
Right. Are there specific target numbers people should aim for when they're monitoring?
Yes, there are generally accepted targets. For fasting glucose, the goal is usually 95 milligrams per deciliter or lower.
Okay, under 95 fasting.
1 hour after starting a meal, the aim is typically 140 milligrams per deciliter or lower.
Under 140 at 1 hour post-meal.
And 2 hours after starting a meal, the target is generally 120 milligrams per deciliter or lower.
Under 120 at 2 hours post-meal. So, fairly tight control.
Yes. Aiming for those targets helps reduce the risks we talked about earlier for both mother and baby.
It sounds like a lot to manage during pregnancy. What happens after the baby is born? Does the GDM just vanish?
That's a really common question. For many, yes, blood sugar levels do return to normal fairly quickly after delivery because the placenta, which was producing those hormones, is gone.
So it resolves itself?
Often, but not always immediately. And importantly, having had GDM signals an increased risk long-term.
Increased risk of what?
Developing type 2 diabetes later in life. That's why postpartum follow-up is so important.
Ah, okay. So you need to get checked again after the birth.
Yes, it's strongly recommended. Usually another 75-gram oral glucose tolerance test, the same kind used for diagnosis, is done around 6 to 12 weeks postpartum.
And what's that check looking for?
It's checking to see if your glucose tolerance has returned to normal, or if there's evidence of impaired glucose tolerance, IGT, sometimes called prediabetes, or even overt type 2 diabetes.
So delivery isn't necessarily the end of the story. Good to know.
Definitely not. Ongoing awareness and potential future screenings are key.
Now, you mentioned the term diabetes in pregnancy earlier. How does GDM fit in relation to, say, someone who already had type 1 or type 2 diabetes before pregnancy?
Right. Diabetes in pregnancy, or DIP, is kind of the broad umbrella term.
Okay.
It covers 2 main scenarios. First, there's pre-existing diabetes mellitus, or PDM.
PDM, that's type 1 or type 2 diagnosed before pregnancy.
Exactly, or sometimes diagnosed very early in the first trimester based on the standard adult diabetes criteria.
Got it.
Then the second category is gestational diabetes mellitus, GDM, which is what we've been focusing on, diabetes first diagnosed in the second or third trimester.
So the key difference is really when the diabetes was first identified relative to the pregnancy?
Precisely. Pre-existing versus developing during.
That clarifies things. The source material also briefly touched on depression during pregnancy. It's obviously a different issue, but stress and health conditions can overlap, can't they?
They absolutely can. Pregnancy itself involves huge hormonal shifts, which can impact mood and brain chemistry, potentially contributing to depression or anxiety.
And would a GDM diagnosis add to that stress?
It certainly can. Managing GDM requires significant lifestyle changes, frequent monitoring, appointments. It adds another layer of things to manage and worry about during an already demanding time.
So what's the advice there?
Well, the general advice mentioned is leaning on self-care, family support first. But crucially, if feelings of depression or being overwhelmed persist, it's really important to talk to your obstetrician or seek mental health support.
Don't just ignore it.
Absolutely not. And it's worth noting, postpartum depression is also a related concern to be aware of after delivery.
Right. It's a reminder that pregnancy affects everything: physical health, emotional well-being. Seeking help is vital.
Totally agree.
Okay, so bringing this all together, after this deep dive into GDM, what are the absolute key things you'd want someone to take away?
I think the main points are GDM is diabetes that starts during pregnancy, usually later on.
Caused by hormonal changes.
Right, leading to insulin resistance. It carries risks for both mom, like high blood pressure, difficult birth and baby, like breathing issues or being large for gestational age. Screening via the OGTT, usually around 24, 28 weeks, is standard.
And management involves careful blood sugar monitoring, aiming for specific targets, often with diet and exercise first.
Exactly. And crucially, remember that postpartum follow-up test, usually 6-12 weeks after birth, because the risk of future diabetes is higher.
So early detection, good management during pregnancy, and follow-up afterwards are all key for the best outcomes.
That really sums it up perfectly.
Great. Well, that gives us a much clearer understanding. And to leave you, our listener, with something to mull over, considering these incredible hormonal shifts during pregnancy and how they impact something as fundamental as glucose metabolism, what other, perhaps less obvious physiological processes might be significantly altered to support pregnancy? And, what kind of research might uncover even more surprising maternal adaptations we don't fully understand yet?